To continue with our topic of heart disease in women, I'd like to invite to the stage Dr. Elizabeth Opheli. Dr. Ofili is a well-regarded, highly respected physician. She's professor of medicine, senior associate dean of clinical and translational research at Morehouse School of Medicine. She's the chief medical officer at Morehouse Choice Accountable Care Organization, member of the National Academy of Medicine, and chair-elect of the Association of Black Cardiologists. She'll come and expand our fund of knowledge on women in heart disease. Thank you.
Good afternoon, everyone. So I was just sitting in the audience there and just marveling at how everybody's just been amazingly attentive, and of course everybody's a scholar, so you'd think they'd be doing their own thing, but people are really paying attention. And that's credit to both of you organizers. I want to thank you for the opportunity. And also, I actually kind of want to borrow this stage. It looks like the Oscars. Oh, I see. Great. That's why it's called Masters. But so my topic, and I do thank my colleagues who spoke earlier, made it a little bit easier for me to navigate. But I'm focused specifically on heart failure in women. And where do I point this to? Yeah, I know, but where do I point it? So these are my disclosures, and they won't really have an impact, except I will in the final slide when I discuss the ABC Cardiovascular Registry. I will talk a little bit about our technology that's being used in that NIH-funded project. So I want to be able to just share with you, specific to heart failure, some of the sex differences, and specifically focus on some attributable risk, and hope that we will together agree on the rationale for sex-specific preventive approaches for both heart failure with reduced ejection fraction, as well as heart failure with preserved ejection fraction. And then utilize the most recent clinical evidence to inform treatment decisions and management of heart failure in African Americans. Of course, given where I spend quite a bit of my time, I also hope we will come away from these discussions with an urgency and really understanding from the standpoint of where healthcare is going, as you heard from earlier speakers, the notion that we cannot continue to talk about disparities and the gap and just share data and not have enough to help people understand what happens in the context of a number of social determinants that we alluded to earlier. And so I was very fortunate actually with this topic, because while I do speak on heart failure, overall I tend to spend quite a bit more time in the ethnic and racial disparities with some effort with women. But fortunately, Jack just did a special session in March of last year focused on heart failure in women, so that actually served to provide some of the information that I was able to pull together. Basically, both doctors, O'Connor and Lilienfeld, talked specifically about how the reason for this special issue was really trying to pull together some of the data that's been out there, but also more speaking to why we need to focus, or refocus, I should say, on some of the research efforts, as well as highlight what's working. So in terms of prevalence of heart failure in women across the lifespan, what you see here probably mirrors some aspects of cardiovascular disease. But interestingly, and perhaps not surprisingly, when you look at women after the age of, once they're in their 50s, there's a dramatic rise in the prevalence of both heart failure with reduced ejection fraction, so-called HFrEF, and preserved ejection fraction, so-called HFpEF. And just so I don't keep stumbling on my words, from going on forward, I will refer to it as HFrEF and HFpEF. That's how we talk about it in the heart failure arena, as those of you who do this know. But again, coming back to the reality here, when you look at prevalence of risk factors for heart failure in men and women, similar to what we saw for cardiovascular disease, but you notice here that the red bars, which represent women, and the blue bars representing men, when you look at hypertension, women have a greater prevalence of those risk factors, and perhaps representing the older age of women when they have heart failure, and also the disproportionate impact on influence of minorities. And obesity is also important for both men and women, as is diabetes, and of course, coronary artery disease. I think population attributable risk from my standpoint is quite instructive. And what you see here for both HFpEF and HFrEF in women, hypertension really dwarfs everything else. And of course, obesity, quite important in terms of women relative to men. And you see their diabetes equally important for both HFrEF and HFpEF. I should mention here, I misspoke, obesity is most important for HFpEF versus reduced ejection fraction. So not uncommonly, as we see in clinical practice, when patients come in with congestive heart failure, sometimes you find a lot of hypertensive heart disease, a lot of obesity, and not necessarily some of the obstructive coronary artery disease. And all of that morphology, I think, is still not clearly well understood, and opportunity for additional exploratory research. So this is one of the questions, one of the papers in the special issue asked the question, is cardiac diastolic dysfunction as part of the postmenopausal syndrome? And of course, we recognize that withdrawal of estrogen leads to quite a bit of the cardiovascular disparities we see in women because of the older age and lack of estrogen. And this really feeds back into, from the microvascular standpoint, increased systemic vascular resistance, to pulmonary vascular resistance, to, of course, what's going on from the cardiac standpoint and muscle. However, with all of these pathophysiology and the physiologic drivers, I should say, we all remember that the Women's Heart Initiative clearly showed that you can't just replace estrogen and have a positive outcome from a standpoint of heart disease in women. So while this is important from the standpoint of etiology and perhaps how we explore new therapy, estrogen from a therapeutic standpoint is absolutely never recommended at this point. The preserved ejection fraction heart failure was also studied from the standpoint of exercise hemodynamics. And interestingly, there was a very good paper that used echocardiogram as well as integrated aspects of invasive monitoring. And not surprisingly, there was, of course, the data that sort of underscored, I should say, what was shown with the estrogen mechanistic data, and that is the fact that the systemic vascular resistance problem, the pulmonary vascular resistance problem, and the myocardial issues in terms of left ventricular hypertrophy and fibrosis seem to play a role in the dynamics of reduced exercise capacity in women with heart failure and preserved ejection fraction. So this is a very old data from 1999 when I first got to Grady Hospital, really asking question about why do we have so much heart failure in this predominantly African-American patient population. And my colleague, Dr. Nanette Wenger, at that time pointed out that hypertension is a big driver, and I had to really go look at the data. And in these 1,200 individuals that were hospitalized over a period of 12 months, as you can see there, she was right. Hypertension was almost universal in terms of comorbidity for hospitalization in heart failure. The other risks you see, perhaps understandable, given this patient population, left ventricular hypertrophy, uncontrolled hypertension in 2/3, CAD in half, and diabetes in 40%. Now, one of the interesting things about this data, this database, as we evaluated it, is almost 60% of the patients are women. One of the gender differences that we noted actually was that the presence of diabetes and left ventricular wall motion abnormality was actually an important, significant driver of hospitalization for women. So this is sort of now kind of historic, but I think there are still things that come back in terms of where we're at today, as you'll see when we talk about heart failure. I just want to, before we leave the subject of some of these female-specific etiologies, I want to talk a little bit about peripartum cardiomyopathy. I know you had a discussion on cardiomyopathy. I wasn't here, so I don't know if this was mentioned, and if it was, please pardon me for repeating. But specific to women, peripartum cardiomyopathy remains an important problem, and part of what we've continued to observe is there are issues around sort of some difference in how women present. Some women will have complete recovery after the baby is born, whereas others will go on to have significant heart failure and some needing transplant. There was a major session at the last Heart Failure Society of America, and Dr. Dennis McNamara, who does quite a bit of this work in looking at new potential drug targets, made an important description, presentation, but we still came up with that. We don't know enough. We're still studying this, and they have a significant study that would hopefully provide us with some answers. And I know this is probably too small to see from the back, but the bottom line here is, as I mentioned, there is a difference in how women present, so a lot of the treatment has to be individualized. You treat them for heart failure when they're acute, but at the end of the day, a number of this is about preventive approaches and preventive strategies for these women, and some women may never have another pregnancy based on how they presented initially. So I just want to bring up a couple of other things that are sort of more modern in terms of what's going on with care and more serious illnesses, such as individuals that have more advanced heart failure and needing to go on to transplant, what's happening with their treatments, such as LVAD, therapeutic approaches or left ventricular assist devices, as well as their effort with transplant. So what this is showing, though, is when you look at these women who are either getting these assist devices or awaiting transplant, there continues to be significant morbidity, particularly when you look at how women are affected versus men. So again, women are in red and men in blue. And so here, the blue bars versus the red bars, I should say. So here we're looking at cerebrovascular disease, multi-system organ failure, cardiovascular disease, infections, pulmonary hemorrhages, and renal failure. All of these issues have women actually having more significant morbidity compared to men. And then when you look at who's actually getting durable LVAD at the time of transplant while they're waiting, as you can see, there's a reversal here, so women are disadvantaged. They're not getting some of these. And of course, it could be because they're very sick at the time, given some of these comorbidities, or it could be because people are just not referring early enough. Regardless, this is an important problem from the standpoint of advanced heart failure. So just to mention some of the discussion, to add to some of the earlier discussion around cancer therapy, what we do know, and again, this was one of the papers that I was pleased to see in the JACC special issue, is, and because I see this in my practice, that more and more women are coming in with heart failure based on, and they have had cancer therapy, particularly the adjuvant chemotherapy for estrogen receptor sensitive cancers. And the bottom line here is, as you can see, when women get chemotherapy, there's already an increased incidence of heart failure, but having the adjuvant therapy dramatically increases the risk, and that's the most, the lighter line to the left versus chemotherapy, which is the darker blue curve. And one of the recommendations that's coming out of this, at least from the American Society of Clinical Oncology is to get echocardiogram within a year of completing chemotherapy. But I think you have to really look at what the women are presenting with. I have had women come to my practice. They have just completed their chemotherapy. It's only been 6 months, and they're symptomatic with shortness of breath. So we have to be sensitive to go in and do the echocardiogram a little bit earlier, and stress testing sometimes needed in these individuals. I think the guidelines will eventually catch up. But this is an important data that was just, again, presented because it clearly showed that 18 months after the diagnosis of breast cancer and completing therapy, women have a twofold higher risk of developing heart failure. But I should quickly point out here that it is still a relatively low prevalence, but we need to pay attention to it. So this was an editorial that was presented in the JACC special issue. I should say actually following the JACC special issue, was not in the same issue. And Noreen Walsh talks a lot about women with heart disease. So I think this is an extension of that thinking, but bears recognition from a standpoint of heart failure. Women, according to this editorial, and I happen to believe that, are unheard, untreated, and unstudied, or if you prefer, maybe underheard, undertreated, and understudied, if you want to be less dramatic. The bottom line is we have work to do. One of the papers that really caught my attention, and this is especially in the context of some of our new therapeutic approaches, and I'll touch upon that in a minute. But when this was an analysis that's being shown here that actually took multiple studies over 4 decades and looked at how those studies reported adverse drug reaction. And what you notice here is there's a reporting of adverse drug reaction across the decades, and this is so from earlier decades on the left to the later decades on the right. The light gray, the darker gray is the overall reporting, but when you look at studies that separated out adverse reactions in women, as you can see, very low rates, 12%, 7%, 6%. So you don't have enough data within these studies to actually define or to report adverse events in these studies. So what does this mean for therapies that are approved and we're out there using them? This sort of summarizes what the problem is. We know that women present differently from men, particularly more common prevalence of heart failure with preserved ejection fraction versus men. We also know that there is increased susceptibility to adverse reactions and perhaps influencing adherence to treatment. So we need to separate out when clinical trials are done to actually understand not just what the NIH really with the Office of Women's Health, people were tasked with defining and analyzing data to make sure we're understanding outcomes, but also adverse events. And unless we're focusing on this, we won't know how this is playing out, particularly for women and minorities. I don't know how many of you saw the recent publication. It was actually a post-analysis that looked at electronic medical records and saw that the recently approved drug based on the Paradigm heart failure trial, Entresto, or sacubitril valsartan, works well for heart failure in whites, but does not seem to have any effect in blacks. Now, this is deja vu all over again for those of us who remember the arguments with ACE inhibitors and blacks and not being as effective. And so this brings us to how far we've come with heart failure, but how much little we know, especially when we're talking about women and minorities. So the TOPCAT information, the TOPCAT secondary analysis that's shown here, also reference the fact that we know the overall TOPCAT data. This is for those who may not remember this. This was looking at heart failure with preserved ejection fraction and whether spironolactone was effective, because we know spironolactone is effective in reduced ejection fraction, very effective. Unfortunately, TOPCAT was not significant in terms of the role of spironolactone, But this secondary analysis actually found that there was significant interaction between sex and the treatment arm because there was reduction in all-cause mortality in women. But we will never know because there was not enough in the overall trial to say, is this something we should be doing differently in women? Again, this speaks to why we should enroll more women, but also be willing to do the analysis based on the number of women in the database. Overall, all is not lost. We have enough information to treat women well and treat them appropriately, but keeping in mind that we need to gather more data. And this is just a summary slide that's saying, at the end of the day, there's value in some of our current therapeutic approaches, and we know beta blockers work well. We know absolutely controlling hypertension is important. I think, and controlling all risk factors are important in preventing both heart failure with preserved ejection, improving heart failure with preserved ejection fraction, as well as heart failure with reduced ejection fraction. And I just want to share again, it's more advanced, so patients who are being hospitalized, but this is good news. Credit to my colleague, Dr. Aneko Anwanyi, who's Chief of Cardiology at Morehouse, and co-director of the Grady Heart Failure Program, actually director of the Grady Heart Failure Program and co-director of the Cardiovascular Service. But this has been going on for some time, really looking at reducing readmissions, and you can understand why hospitals want to focus on this because of the cost of care. And the data has actually been quite persistent now in terms of patients that are being readmitted, much lower numbers, and the program that was put in place in terms of consultations, as you can see, pre and post consultations, almost a 50% reduction in patients being readmitted. And this has been tracking this over time from 2018 to last year. So that's the good news. This is the not so good news. In terms of disparities for heart failure with African Americans with heart failure. And we know why this is it. You heard some of this today. I'm sure you heard some of this as well in the earlier sessions yesterday. But when it comes to actually treating these patients, it seems that we're still falling short. I'll just give you this example. This is a 58-year-old woman who presents for follow-up. She's been hospitalized with heart failure 6 months earlier and was sent home on these drugs. And for those of you who've heard me speak before, you know I'm immediately going to say something is missing here, and I'll just keep my powder dry for a second, as one of my mentors used to say. But so she's on valsartan, carvedilol, because she's allergic to enalapril, furosemide, and I think this was maybe a few years ago, but probably after Paradigm, someone would have probably had her on sacubitril as well, because a number of my colleagues are definitely doing quite a bit of that. But based on the evidence that's out there, there's something that's missing in this patient's care. Who knows what that is, since you guys haven't been privy to my soapbox? Can anybody tell me what's missing in the care? Except for Dr. Hutchinson and Dr. Shigadi, you can't say anything. What's missing? I'm not hearing anything. So I'll help you guys out. Fixed dose combination isosabide dinitrate and hydralazine is missing, also known as Bidil. We remember this study because the Association of Black Cardiologists was very much involved with this. This was published back in 2004. It has this kind of data, and the placebo is everybody else who was getting ACE inhibitors and beta blockers and spironolactone, et cetera. And yet this treatment worked. And 15 years later, less than 10% of blacks who qualify are getting this therapy. So I should say too that almost 50% of the participants were women, so this is also relevant to women. So this patient, if she had a voice, would probably ask some questions. And I've had patients in my practice who's been around different hospitals in Atlanta, have not been put on the appropriate therapy that's been proven for blacks, and have come to see me, and I've tried to correct the wrong, but our practice, we're only one practice. What's happening around the nation to me, is a travesty in terms of the appropriate care of African American patients. I just want to share this as we come to a close here. As part of the data, the heart failure, JACC heart failure special issue, I was pleased to see a patient's voice. This is a woman who's living with heart failure. And as you can see, she's been, well, you can't see because you didn't read the paper, but I'll tell you. She's been working with a number of women and community groups to raise awareness about heart failure and need to participate in clinical trials. Well, she had some comments about, we don't prioritize clinical trials enough because sometimes when we have information on the website and a patient would call, somebody will say, what now? What are you looking for? Because most of the practices, most of the clinical practices are not necessarily doing clinical trials, and the shops that are doing clinical trials at academic institutions are just doing clinical trials. So I think part of the transformation that I'm going to close with is why we need to integrate clinical trials with care. So this woman, for example, said, we do clinical trials because we want to know about timely treatment. When the new studies are coming out, we want to be a part of that. She believes that it helps with understanding what's going on with care. If you can imagine when you're diagnosed with a condition, you want to look and see what's out there that's new and novel. She states that as a patient, considerate treatment should not just be during the clinical trial, but before and afterwards. In other words, communicating the data with the participants and sharing with them and seeing how are they doing and how can you get that therapy to them if the treatment worked. We did that with the African American heart failure trial. Everybody in placebo was eligible to receive the treatment once we got the data that Bidil was effective. All right, unlike my previous speaker, I don't have President Barack Obama telling people that the injection will hurt. I have President Barack Obama giving a press conference following the final State of the Union address. Many of you may not have recalled that, but I'm very much into precision medicine, so I remembered that he gave a press conference following the 2015 State of the Union, and the whole excitement was around precision medicine. And he was particularly interested about the opportunity to get new medical breakthroughs. I should say here that leading up to this, obviously, is a lot of effort that has been done through that administration through the Office of National Coordination on aspects of data science that folks like me who do research are starting to reap the benefits of that. But also importantly, as a result of this, there is a whole effort to recruit 1 million diverse Americans in the program that's called All of Us. I want to give credit here to Priscilla Pemo at Morehouse. She's part of the Southeast Enrolling Center, and they are, along with University of Miami, Florida Gainesville, and Emory, are doing a good job of bringing in diverse patients. But this is all over the country. And I'm particularly interested and excited about this because I think it's starting to turn the tables a little bit and put some emphasis on what the patient wants and what the patient needs. So the patients begin to ask us questions, and when they participate with us, we have to take their point of view more significantly into consideration. So I'm going to close with this. The ABC Cardiovascular Registry happens to be one of those projects that have had a long time coming. I have two past ABC leaders here, Dr. Barbara Hutchinson, as well as Dr. Felix Chagade. Both of them, as leaders, were interested in this, and I have to say they put their practice where their mouth is, or they put their practice where they don't have big mouths, so I was hesitating to use that analogy. But the reason ABC Registry is important is because I've talked about all the things that we've really mentioned over the years about disparities and equity, and yet registries have been done, and they still have majority patients, few African Americans, we don't have enough emphasis on social determinants of health. So one of the opportunities we have, especially since, at least in the United States now, most practices have electronic medical records, is to begin to look at transforming how we do registries and clinical trials, so we're not having these sunk costs in a warehouse that becomes obsolete, or in a data warehouse that becomes obsolete because treatments have changed. It would be good if we can just go in and query the data that's in practice and have information that can support a clinical study, or better still, an information that can influence the quality of care as care is being delivered. And this is what we're doing with the registry. We just got some funding from NIH to implement a technique called FHIR, F-H-I-R. This is where you can actually go in and interrogate the electronic medical record in real time, pull out data, ask questions, and have the information stored in the cloud, so it's not as expensive for some of our participating practices. I believe this effort to democratize research, democratize data science, and importantly, democratize who has access to the data, because the cost and barriers to entry have to be significantly reduced if we're to make any impact on all of these conversations about health disparities and health equity. New treatments that may or may not work because they weren't studied, and we're forced to use them because that's what's been approved. And I thank you for your attention. So, are we going to have anybody else join, or I just stand here? I just stand, okay. I thought we were gonna sit on the fancy couch, but that's okay if we're not.
Actually, the fancy couches are waiting for Drs. Knopp, Dr. Spencer, and, well, it's just you in our, and Dr. Ferrari. So if you all have any questions, particularly as it applies to women in medicine, women in heart failure, women, and how we present with coronary artery disease, it's really important. And this is also something that leads into our lunchtime talks. Obviously, we're running a little bit late because, of course, you know, island people time. You all came a little late, and we wanted a full audience for our speakers. But it's particularly important for us to talk about how women present and how we treat them differently sometimes and underestimate the impact of disease, because we're not seeing adequate treatment in our populations, and we're not seeing enough attention paid to what the actual impact of heart disease is in our population in general, but particularly as it applies also to women. So if anybody has questions,
yes,
we are anxious.
Dr. Elizabeth, I really feel supported in the sense that you mentioned the ridiculous amount of Black people included in the Paradigm trial. It was about 215 persons, and most of them African Americans. That motivates us here in Jamaica to do some observation in our population. So, because we were really in the same matter of, we have no any proof that the RNA therapy is effective and safe in our population. They mentioned angioedema. They mentioned improving in the ejection fraction. So we start some observation. Our cohort is still growing. However, we have definitely more consistent data now. We have a heart failure with ejection fraction treated with RNA therapy, and for some reason, I don't know if the microvascular illness is most important here, because non-ischemic cardiomyopathy is the most prevalent, but apparently some vasodilator effects of the ARNI is making a good effect because we are seeing reverse remodeling in a spectacular way. The data is not published, but probably we have, and one commenter. And second, Dr. Ferrari, Takotsubo syndrome is very important. The link in Takotsubo is cardiac dysfunction and stress probably and adrenergic drive. So one comment in the images.
Okay, so Dr. Ofili, he's asking about ARNI and that we're seeing really good results here. So I'll let you
Yeah.
take it first.
Hello? Oh, yeah. So thank you for that. And I think that I also hear that. And one of the challenges we have in medicine is we treat one patient at a time, and we make some conclusions. Of course, we want patients to get better. And I've heard of reverse remodeling. But the challenge I have is the data is not large enough. And I honestly don't know what else those patients are not being treated with. So I think I applaud you for using the sacubitril valsartan, but I would say, at least based on the patients that I see, and I've said this in major meetings, I think the impact of hypertension on the microvasculature, the fact that we have demonstrated on multiple data and research that there is some level of nitric oxide deficiency in patients who have predominant hypertension, diabetes, not necessarily just about blacks. So I am, oh, the lights are changing. Woo! Somebody is trying to trip me up here. So, I mean, again, I think it's commendable that you're doing that, but I want to just continue to say, we should look at therapies that have worked in the patient population that we're seeing, because the social determinants of health could have an impact. If you didn't recruit those people, and they were just people from Europe, which was the predominance of the data, how do you know it's going to work for your practice, right? So that's just my challenge. And we still have to treat people, so I think we should treat people, but I think the bigger picture, in the not too long distances, we've got to have the numbers and have these unique registries that would allow us to answer the question. Sorry.
Okay. And then it was you, Dr. Ferrari.
I wanted to be clear about your question or comment about Takotsubo to be sure I answer it properly.
What is the best images test to assess Takotsubo syndrome?
I see. Great. Thank you for the question. I think ECHO provides the best value and also the quickest screening for the procedure. Now, interestingly, Joao Lima and his colleagues published a very nice study in the New England Journal of Medicine. I'll refer you to that, to look at some of the mechanisms underlying Takotsubo cardiomyopathy. It's really exciting that we have two types of cardiomyopathies that are reversible, Takotsubo and also, in general, the cancer, the adjunctive cancer therapies causing brief and usually reversible cardiomyopathies. Understanding the mechanisms of those changes could help us understand longer-term problems with cardiomyopathies and potentially provide clues or targets for preventing or even treating cardiomyopathies in general. It's a very complex issue, obviously. I'm not trying to oversimplify it, but just to say we have two near-term types of cardiomyopathies that are reversible and we can study more clearly. CMR may provide some additional insights into that above and beyond just imaging the structure and function.
I wonder if peripartum cardiomyopathy feeds into that as well, because sometimes after pregnancy, they become completely better, the ejection fraction goes up, and some of them, when they have another baby, get pregnant again, the heart failure section. So I mean, it sort of fits in that, some reversibility.
You're absolutely right.
Right.
And Zoltan Rani, who was one of the co-authors of the article you showed on
Right.
peripartum cardiomyopathy
Right.
at our center, has been doing some very nice work with at the basic science level and translating that to humans. Imaging, again, in that regard. Echo is the predominant modality, but CMR also provides some insights if it's not reversible, to determine how much scar is present.
Right.
Are there any other questions?
Yeah. This question is, I think, directed mostly at Dr. Spencer. I currently work at a Mayo Clinic. I'm also a member of the U.S. Preventive Services Task Force, and I say that because I believe prevention is better than cure. But also, very clearly, there is a resource issue in these communities where the needs are really great. And yet the access to the expertise and the resources aren't there for us to deliver the care that's needed. So I guess the question, Heart Institute is really well known for telemedicine. What I didn't hear from your presentation was the role of telemedicine, or telemedicine could play in the delivery of more specialized care. Instead of people coming into your operating rooms to provide assistance for surgeries, is there a role, for instance, in telemedicine in delivering the surgical procedures that are needed, even for CABG or other procedures?
That's a difficult question. Telemedicine in assisting surgical procedures is probably not something that is required in our setting. It's not that the persons operating do not have the expertise to do the operations, which is what I understand from telemedicine helping the operative process. It's lack of certain materials that is our problem. And as you know, the cost of these materials is quite significant. And to try to address the cost, one has to determine who will provide the funds for the cost of this material. Our health service is highly dependent on contributions from the health ministry. But unfortunately, the funds, approximately 70% of the funds that are provided by the Ministry of Health go towards salaries and rather than basic renewal of equipment and so on. I don't know if that has answered your.
Okay, I'll go. Yeah, two questions, one for Dr. Opheli and one for Dr. Ferrari. I'll go with Dr. Opheli first. I like the slide you showed about the role of estrogen in inhibiting the oxidative stress and thereby impairing or delaying apoptosis, And we had a great lecture this morning from Dr. Anderson about the role of reactive oxygen species, and I know a question came up whether there was a sex difference in some of these things, and I think that probably shed some illumination on that. I don't know if that's something Dr. Anderson may comment on later as well, along with your answer to the question about what specifically how estrogen plays this role. I think we may need to have more information because we know just giving women estrogen alone does not solve the problem. And the second question for Dr. Ferrari is the role of, the best imaging modality for women. As you know, when we go to fixed imaging using CT, which is actually being pushed by a lot of health systems in the United States now, CT-FFR, and I'm kind of quite impressed that you showed that the cost is significantly higher. But in addition, we have a lot of incidentomas as well. There are a lot of breast lesions that will be picked up, maybe sometimes, and of course, a lot of lung lesions that, just leads to more and more testing. Whether this actually long-term results in clinically advantageous situation for the patients needs to be defined, but I don't know if you have any data to guide us about all the sort of things that we see in the process. Sometimes we feel very good that we saw something. I just walked up a patient that had triple vessel disease, just came in because his brother died, but then they saw a lung scar, went to operate the scar, they took out part of a big chunk of the lung, the lesion was benign, and just worry about, what are some of the consequences of, we need to define it a bit better.
So to respond to the question, the comment and the question about the potential, definitely the potential role of estrogen and opportunity to continue to explore that. So as a non-basic scientist, when I look at some of those pathways, I'm clearly understanding that there are many things that obviously affect the oxidative process and how that influences the vasculature and inflammation. And estrogen definitely plays a role, and the problem though is when you begin to look at a therapeutic approach, most people don't just take estrogen, right? And even with the contraceptives, when you give estrogens and low-dose estrogen, there's still a danger that's related to other aspects of estrogen, whether it's on the blood pressure or on the thrombotic risk. So I think the totality, when you go beyond just the isolated physiology and the cellular activity, is what happens in the real world when women who are older, who may have incidental and undiscovered and untreated coronary artery disease, and they're treated. And I think that's part of why we had this big problem with the Women's Health Initiative. Is there a way to further refine that and think about maybe getting the benefits of estrogen without the risk? I suspect people are still experimenting with that. And right now, there are people doing that in the non-mainstream market, the homeopathic people and people who are doing natural medicine. But the problem is the data is not there, just like we all swore about the benefit of estrogens because women felt better, but didn't know all of these downstream effects and that people were dying from heart disease. So it's not a good answer to your question, but I think your question probably raises a lot more questions about how we should design these studies to understand better how it can be applicable to real people. So I don't know, Dr. Anderson, he threw a thing at you. You wanna, did you wanna comment?
I would just say that this is a huge unanswered question. I pointed out, sort of my struggling for a good word, but shame over not addressing that. We do see sex-dependent differences in lots of animal models. We have really rarely followed any of them just because it doubles the number of studies that we have to do, and we don't have funding to do it. But I think it's a core issue that we have to work together as more early and late translational scientists to advocate for the kind of structure and funding to make this happen.
Thank you for your terrific question, because it gets to the core of our medicine and society theme. And that is, what is the individual, or how do we balance the individual benefit of testing versus the population benefit of testing? And also, how much of our country's resources do we put into preventative care or diagnostic imaging? In general, women develop coronary artery disease, symptomatic coronary artery disease, about 10 years later than men because of the presumed estrogen benefit, or at least sex hormone benefits. And therefore, they are generally later in the course of their disease when detected. But the early detection that may be possible with coronary CTA, particularly the diagnosis and detection of non-calcified plaques. And I think that's in that window of the 45 to 64-year-old females, that's where the coronary calcium score is not helpful, but coronary CT angio will pick up very small calcifications that plain calcium scanning don't, but also the non-calcified plaques predominantly. Fortunately, it's rare, but for those women that have that disorder, they are at greater risk of having an acute MI because of the remodeling of the fibrous cap of the plaque and rupture of those plaques. What we need, and to get to your question, what we need, I think, are better population-based, gender-based, and ethnic-based studies to know when the role of cardiac imaging, particularly coronary CTA, is cost-effective and where the tipping point is for balancing society's benefits and the individual's needs to be treated. What would be great is if we had a simple blood test, something cheap and accurate, that could detect maybe an active plaque or remodeling of the fibrous plaque within a lesion that would be rapidly deployable to many different parts of the country. We're not there yet, but I think we should move our sights toward simpler non-invasive testing and less expensive non-invasive testing than we have now. But we can't treat patients with tomorrow's technology today at the moment. So.
Okay. We have time for one more question, and
just a quick question. It's not really a question, it's just some clarification for Dr. Ofili. I just wondered whether, if I get you correctly, you're urging caution with the use of sacubitril valsartan in African populations. Felix may have neglected to tell you that he actually presented our data at the European Society of Cardiologists Heart Failure Summit in Greece a few months ago. And we have very impressive reverse remodeling data. Secondly, that the cost of sacubitril valsartan is a fraction of what it is in the United States. What I wonder is the possibility of sort of maybe unintentionally withholding sacubitril valsartan from African American populations, particularly those who are uninsured. You're depriving patients of a potential benefit. Not that it's harmful, but its question is, could that be, part of the? You have a study with low numbers in terms of representation of African Americans, and should that be the basis for consideration, or should we have data that drives decision making in our own local environment?
So I think that I'll tell you what I do in my practice, but I think you should do what works for your practice. I think at the end of the day, when there's insufficient data, people have to act based on clearly what's available and what will be helpful to the patient. Drugs are approved, and so I don't think I would withhold at all. When you look at the data, though, from the FDA review, there was more significant, almost an 8-fold rate of angioedema among black patients versus non-black. Huh? So that's good. And I think to the extent that you're continuing to follow the patients, I would not withhold sacubitril valsartan from a heart failure patient, especially if you have access at a low cost. Based on the AHEF trial, though, in my practice, I first use fixed-dose combination acesulfame dinitrate and hydralazine. I know that sometimes people talk about the number of pills, the pill burden, but in my experience, you can get away with 2 pills a day and people get better, and we also have seen reverse remodeling. But I think all of these drugs, perhaps because there's some influence on nitric oxide, because certainly sacubitril valsartan has some of that effect as well. So I don't mean to confuse or miscommunicate. I think patients should be treated based on the best information that's available, as well as the economic impact of care. But we should not make an assumption that patients cannot afford a certain treatment if it's the best treatment that's based on the data. That's what I would quarrel with if we assume that something won't work. But it sounds like you're the opposite. You've gone for the diamond, and you figured out a way to get it to the patients and treat them, and you have not shown side effects. So keep gathering that data, because it will take thousands and thousands of patients for us to really know long term. This gives me an opportunity to point something out. To the extent that we're all looking to artificial intelligence to help us as we gather more data, there still needs to be caution, because recently there was a whole brouhaha with United Health Group, because we found that some of the data they were using was actually adversely impacting Black patients. I think all of this speaks to sometimes when you don't have adequate data, sometimes your conclusion may not be correct. I'm not saying that's what's going on here. I want to be very clear. You follow the patient. How many patients do you have in that group that you're talking about?
Probably under 100. But,
Under 100.
compared to a few hundred in Paradigm.
Yeah, under 100. So keep tracking and keep following. And quite frankly, if you are not in the context of a registry, at least if it's in our case in the US, sometimes patients may have an adverse event. They go to one hospital. If you're not tracking them, you may not know what happened. So I encourage you to have, as best you can, since you have this number, grow it into a registry.
Okay, excellent. That ties into what my belief is, in that just because you think somebody can't afford to pay doesn't mean that you shouldn't give the best advice about care. And obviously the best advice is not always cheap, but we will try to do the best we can. So we thank